Hi, Neeraj.
Sir, good evening, sir.
Good evening, good evening.
So we'll be starting in a minute or so.
Yeah, sure. No problem.
Good evening, everyone. It gives me immense pleasure to welcome you all to the first webinar of our series titled Food Allergy Awareness to Action, organized by IAP Allergy and Applied Immunology chapter in collaboration with the Center for Food Allergy and Asthma Research, CFAR, Chicago, USA. We are launching this timely initiative during Food Allergy Awareness Week, which started yesterday, to highlight the growing burden of food allergies, especially in children, and to empower pediatricians, healthcare professionals, and caregivers with practical evidence-based knowledge. Food allergies are no longer a rarity in India. From gastrointestinal issues to life-threatening anaphylaxis, they are presenting in varied forms and often remain underdiagnosed or mismanaged. Through this series, we aim to bridge the critical gaps in awareness, diagnosis, and management of food allergies in our unique Indian context. Today's session, Cracking the Code Food Allergy in Children, brings together leading experts who will delve into the epidemiology, clinical relevance, gastrointestinal manifestations, investigations, and the evolving role of microbiota in food allergies. I sincerely thank our distinguished faculty from both India and abroad for sharing their insights and contribution to this mission. I also thank Dr. Neela Mohan ma'am. She is President-elect of Central IAP for 2025. She is also Director and Head of the Department for Pediatric Gastroenterology and Hepatology and Liver Transplant at Medanta, the Medicity Gurugram. So, ma'am, welcome you. And let us all work together to move from awareness to meaningful action, ensuring safer, healthier futures for children across our country. Thank you. Thank you for joining us. And I would like to invite Dr. Neela Mohan ma'am for her address. Ma'am, please.
Yeah, thank you so much, Neeraj. It's indeed an honor and pleasure. Good evening to everyone there and those who are across the country, across the globe, rather. Good morning to them, because even I am right now in Mexico. I'd come here to attend the IPA, that is the International Pediatric Meeting. And so it's a very good morning from those who are in the West. So, as I mentioned, it is to start with, I'm truly honored to be on this platform, which is so interesting of the webinar series that was the need of the day. Though we are starting with cracking the code food allergy in children, what I've gone through the program and it is beautifully designed to talk about in the next two webinars, the various challenges that we face in investigating, treating these children, the role of immunotherapy, and gut microbiota, etc. And are we lacking behind in our research? I think these couple of days we were going to address this. What we thought once that food allergy is something for the West and is not our baby, I think we proved ourselves wrong, because though the chapter was designed, is a 15 years old baby, I would like to congratulate them because they are marching with the need of the day. And Neeraj in his program today realized that food allergy is gaining more importance, and it is not only seen in the West, but it is knocking our doors. And these doors, it is not only knocking in the urban, but also in the tier two cities and tertiary hospitals that we get to know. And sometimes I ask myself two questions when I talk about food allergy. Are we missing allergies? Or are we overdiagnosing some of these babies due to the availability of the test which people are not able to interpret? For example, a couple of days or week back, I met a child who was 3.5, 4 years, and it was quite sad that the child was on a severe food restriction based on a diet which was on a blood test which was IgG. And so there was so much failure to thrive besides the anxiety in the parents. And you all would just enlighten the pediatricians how wrong it is to just depend on some food allergy panel tests that are available, which may not mean anything. These are just stories to just to enlighten you what we come across in our day-to-day practice. But at the same time, ordering this test without clinical correlation for multiple food is not only unscientific but potentially harmful, as I saw this child was with failure to thrive. So these webinars, which are under the leadership of IAP Allergy chapter, under the leadership of Dr. Neeraj Gupta, who's the president, as well as Upin Narayan as the secretary, and Dharma as the uh, treasure. I would sincerely like to compliment you all for the various steps taken and the way you all have now taken Allergy chapter to the place where it truly deserves, as you all have planned not only this, but the various protocols, the books, and I have also offered a workshop in the upcoming Pedicon 2026 to be conducted in Calcutta on January 16th is the workshops. So through the workshops and TOTs and the various programs, and we hopefully might be able to release some book if the chapter works with the speed that they are envisaging. And I see the enthusiasm in Neeraj, who is, and of course, the foundation laid behind by the other senior pediatricians, people like Parmesh, people like Krishnamohan, who have been doing a lot of work in allergies too. So thank you for setting that platform and handing it over to Neeraj, who was the right person to steer it this year with a very methodical and a planned program of his presidential action plan. So these webinars that we are going to see are going to make us talk about the burden of the clinical manifestations, which is the IgE and the non-IgE, learn how to interpret these investigations, balancing this in vivo test, learn a little bit about the microbiota and its influence, and what is the role immunotherapy is playing, and how to update ourselves with the latest research that is going on. Sadly, what I see globally, they say maybe 7-8% they see food allergies. We do not have any concrete data in India to this, and hopefully as we are marching, we should be do. And as Neeraj has introduced me, not only as the president-elect of IAP, my hardcore passion and practice is pediatric hepatology, gastroenterology, with a good amount of work being done in allergies. And of course, there's so much to learn from stalwarts from like you all in this field. So with the commitment of the chapter, I see that we are going to advance a lot in our country. But as we progress, I want to urge all of you, who the pediatricians, that when they approach the food allergy, please maintain a clarity, a balance, and a compassion. Just putting them off may not be right. Let this be a journey of a clinical insight, and above all, a child-centered program. As I can see, I would fail in my responsibility to sincerely congratulate the Center for Food Allergy and Asthma in Chicago, USA, for the endeavor to join hands with us, because there's always enough to share through knowledge. There will be something which we as numbers would be able to share, because though it is 8% there, and even if we are going to be less than that, the sheer numbers that we have in our country with 45 million children, you can imagine what we would have to share with each other. So on the across the border, I would like to congratulate Dr. Maha and all the other the speakers that who are going to join us: Helen, Hugo, Jessica, Ruchira, Anna, Vinay. Thank you for giving your time to us. And we are truly pleased to have you all over in these webinars in India. And of course, the dear faculty from India. Thank you so much for joining and supporting the efforts of Neeraj and Upin in terms of Mahesh, Nishant, Sai, Soumya, Krishna Mohan, and Anil Arora, who's my contemporary in the adult side, because they have curated one program on the adult food allergy and EOE. That was also commendable. With those few words, I wish you all great learning in this through these webinars, and was in fact expressing my worry to Neeraj is, now I understand that yes, it was the allergy week, but at the same time, the ESPGHAN, which is probably the highest attended pediatric gastroenterology conference globally, is right in those times from 14 to 17. And that's how I'm going to be personally missing maybe a few of the sessions. But it was really important to have a kickstart, and with the various way we are going. 3 cheers to IAP Allergy Chapter, 3 cheers to IAP National. Jai Hind, love to all of you all for doing this academic journey.
Thank you very much, ma'am. Thank you for your blessings. Just to mention that all these webinars are actually telecasted on YouTube, and this YouTube channel is of IAP Allergy Chapter. So anyone who wants to go back, recap, so everything will be available. So all the time on the public platform on the chapter YouTube channel. But thank you very much, ma'am, for your blessings and joining from different country, from across different time periods, 12 hours time period. So that shows the commitment, that how committed you are for the activities of IAP, for the children, and for gastroenterology. Thank you very much, ma'am, for your blessings, ma'am. Thank you.
Best wishes to everybody.
Ma'am, thank you. Now, as Dr. Nilamohan ma'am has just stated, so let us begin. Let us start. So any beginning of any particular disease starts with something like epidemiology. So we will be discussing about food allergy epidemiology and clinical relevance in India. And I cannot find any better person than Dr. P.A. Mahesh. Dr. P.A. Mahesh, sir, is Professor of Pulmonary Medicine from Mysore Medical College, but his main introduction is that he is the lead researcher of Europreval study, which is the biggest, largest study, and he's the lead researcher from our country who has actually taken made deep efforts to study about food allergy. He is one of the among top 2% of the researchers in the world for consecutively past 5 years. Sir, you are welcome and thank you very much for joining us. Please share your screens and please share your insights, sir.
Yeah, thank you, Neeraj. At the outset, I would like to thank the IAP and Neeraj in particular for having given me an opportunity to share my thoughts with you. Can you see the slide?
Yes, sir. Please go on the slideshow, sir.
Yes.
Yes, sir. It's perfect. You can start, sir.
Yeah. So thank you, everyone. And again, thank you, Dr. Neelam, for a good sort of introduction and joining from kind of other side of the globe. So this is it's very important to understand because the scenario in India is entirely different from the scenario in the West. You will have noticed Dr. Neelam said knocking the door. I think that is where we are. So why should we worry about food allergy? After I finished this Europreval study, there was some interest by the ICMR. After I presented the data, the person said that there is no need to study food allergy. It was one of the very senior members of ICMR. I said, sir, you have to study it because you have to know the protective factors. People are worried only about the risk factor. But the Indian behavior, Indian diet, Indian lifestyle is protecting us against food allergy. And generally, food allergy starts peaking about 2 decades after allergic rhinitis and asthma starts peaking. And, we are right there. Unless we are very careful in retaining our protective factors, just aping the West in their lifestyle and the diet is going to lead to catastrophe in the Indian population. When I was in Spain in the pediatric department for the workshop for the Europreval, to do one proper food challenge, it takes 2 doctors, about 6 to 8 hours in a day, for 2 days, for one child, for one food. And the doctors don't do anything else the entire day. So you can imagine how intensive food allergy diagnosis is. 2 doctors, 2 days, one child, for one food. If the child says 3 food allergies, you're done. Can you find me that situation in India? I don't think so, ever. So therefore, I think we should really concentrate on what is protecting us and try to retain it, for which a lot of research is needed. The key thing compared to the Western world, I have no disclosures, is the beautiful city of Mysore. This is the Golden Throne and the Dasara and the Mysore Palace with the lights on. First of all, again, Dr. Neelam pointed out a very important clinical situation that is very commonly seen. We need to understand between food allergy and food sensitization. Sensitization is presence of IgE antibodies. And most often in countries like India, Southeast Asia, Africa, these food so-called IgE is present in the absence of clinical symptoms. They show an IgE antibody to a food. You ask them what happens when you eat the food. They say nothing. I eat it very frequently. I have no problem. So you have to neglect it. So this is only sensitization. There is no clinical disease. Food allergy is when there is an adverse health effect rising from an immune response that occurs reproducibly. It's important to understand that on exposure to a given food. So this is very, very important difference. I think a lot of doctors, forget about the lab people, a lot of doctors themselves feel that presence of IgE means there is food allergy, and that food the child has to avoid. Even more extreme form of stupidity is looking at IgG by doctors as a diagnosis of food allergy. We produce IgG to everything. We produce IgM and we produce IgG to everything. It doesn't mean there is food allergy. That is the extreme form of stupidity, I would call. This, I would not call that. People are not aware, but that's, really, very, very bad. Now, the prevalence may be 1 to 2%, but less than 10%. This has been the data because proper food allergy studies have not occurred in the community in many countries in the world. So we are not very clear. So we did this study, that is the Inaugural study, long time ago. It was the largest study of food allergy in India and the largest study of food allergy in the world, to the tune of about 165 crores. That was the budget for this study. 65 centers across the globe. In the second step, 3 countries joined. So I led India, and then as tropical, Hong Kong, China, subtropical, Siberia, subarctic, different people, different genes, different food habits, different environment, different genes, and they were compared to the European countries. So out of we had it's a 2-phase study. First phase just questionnaire. Second phase we did the skin prick testing for 24 food allergens and 6 aero allergens, as well as serum specific IgE for this same. So both were done. Now, this is what we got for adults. We got exactly similar value for the children. If you look at the brown form, that is what you got for the combined Europe, and the blue for each of these foods is for India. So what do you see? Even for foods like, for example, kiwi and celery, which are hardly consumed in India, you find that the blue bar is much, much higher than the brown line. So what does it mean? Indians are very high IgE producers. Similar to Indonesia, Africa, we are also very high IgE producers. IgE is not only associated with disease, IgE has a tremendous protective effect also. If you are bitten by a mosquito, you are bitten by an insect or an ant, what's going to detoxify the venom? It's IgE. You eat irritant foods. What is going to detoxify that? Again, it is IgE. So IgE, including anti-cancer effects, every country that has high IgE in their population, you will find less cancers. IgEs, the countries where IgEs are low, you will find more cancers. So there's a lot of beneficial effects of IgE. It is not always bad. That is also important to understand. So we are high IgE producers. If you look at the number of people out of the whole population, and this is a normal population, this is not a disease population. This is normal population. If you look at the entire population and see how many of these normal people who never had any allergic disease or symptoms, how many of them had a positive IgE, more than a quarter of the population have a positive IgE. And nearly 1/5 of them feel their symptoms. It is nothing to do with food allergy, but they feel whatever symptoms they have is related to food. They have a headache, they relate it to food. They have a leg cramps, they relate it to food. So Indians, because maybe of the influence of Ayurveda, they feel all their disease is due to food, and change in food will modify their disease. People with probable allergy, it means there is a specific IgE. And if you ask the patient, suppose for example, there is an IgE to milk, the mother says the child takes the food, within half an hour or 1 hour, the child has these IgE related symptoms. That is what we call as a probable IgE. We did not do a food challenge, so this is going to be much lower if you actually go ahead and do a food challenge. And this was very intimately related to the total IgE in the population. The mean IgE, because there were extreme outliers, mean IgE in our population is 550. But if you take a median, where the outliers don't matter, our IgE is still very high, whereas the lab will tell you it is less than 100 or less than 120. Our median IgE is double that. And if you were to classify the group as less than median or more than median, this 1/4 of the population who were positive to any food, you will find that it's nearly half the population when the total IgE is high, and when total IgE is low, it is almost negligible. It's about less than 5%. So when the total IgE is present, sensitization also is going to be very high, nearly half the population. And please remember, these are normal, healthy population. They do not have food allergy. They do not have asthma. They do not have allergic rhinitis. And this is the data. So if you want to interpret serum-specific IgE, you have to be very careful. You need a very strong clinical correlation. We'll see what these are. Again, that is one point that Dr. Neelam stressed in her introductory remarks. And the same thing we again tested about 6 of the aeroallergens. The results are the same. Interestingly, if you look at, for example, India and compare the skin prick test and an IgE, you will find there is a huge difference between the skin prick test versus serum-specific IgE. Because for a skin prick test to be positive, the IgE has to sit on the mast cell close to each other. 2 IgE molecules will bind to one allergen to cause degranulation. Whereas a serum-specific IgE in the blood measures free IgE. It is not sitting on the mast cell and the basophil. So the skin test is the most important test. That is the gold standard, not the blood test. In countries like India, where they are high IgE producers, there is a huge difference between the positive skin prick test and the positive serum-specific IgE in the normal population. If you go to country, for example, like Norway or the Netherlands, there is not much difference between the two. The skin prick test as well as the serum-specific IgE are positive. They have a much higher disease rates as well. If you go to Indonesia, it's even more stark as compared to even India. The only country that is similar to India in Europe is Greece. And Greece had the lowest prevalence of food allergy. We also looked at the role of infections and sensitized, not disease, infections. So the antibodies were positive, anti-HPA, toxoplasma, and salmonella. This is Mysore and Bangalore data. We had very high anti-HPA. None of these people had any severe disease or jaundice. These children did not suffer from those, but their anti-HPA was positive. The only country in Europe that did that was Greece. Again, Greece had the lowest prevalence of food allergy. Whether it is simple observation or it's a surrogate marker of the lifestyle of the people, or these infections really have a role, we do not know. Unless we do a longitudinal study, we cannot answer that question. Now that one slide data that I showed you was for children, was for adults, but again, this is a series of slides. I won't go into the details for the lack of time, is for children. After Hong Kong, they also roped in 2 cities from China, also joined in. So this paper has been published in JASI in practice. Again, if you look at the positivity rate, very similar to that what we see in Indians. Again, these children are healthy. They do not have any food allergy. After screening 32,000 people, we got about 26 people with probable food allergy. So the number is very, very small. I'm not going to go into each of these numbers. Again, peanut is very high. We had no single case of peanut allergy. I won't go into the details. These are very high numbers, even much higher than Hong Kong. Among the countries, Hong Kong had the highest actual or probable food allergy, followed by Russia, followed by India. India had the lowest prevalence of food allergy, the highest prevalence of sensitization. Now, this is the all the various foods that were tested, and this is probable food allergy. Again, starkly you will see the difference. Hong Kong is 2.7, whereas India is 0.11. The lowest is rural China. This is rural China. This is in one of the Chinese cities. Rural China is still more than 2 times higher that of India. These are again for different foods. We had 2 cases of egg, one of peanut, and we had almost nothing for the rest of the foods. Very little food allergy. So the lesson is we need to be very careful when interpreting the serum specific IgE in the Indian population. More than a quarter of the population are sensitive to one of the common foods. They do not have food allergy, and the actual prevalence is very low. Those we have very high sensitization rates. What could be the protective factors? We are still unclear. One of the interesting things we did was look at the sensitization rates based on whether their consumption of the food, whether the vegetarians or non-vegetarians. You find a major difference. This includes both the adult and the child and the children data. And that remains for the inhaled or food. Again, we find that there is a stark difference. At first look, I was wondering whether it is true. Have we collected the data correctly? That was the first thought in my mind. And then we had this very nice Nature review that actually looks at, we don't have the enzymes to digest the fiber. Then why should we consume the fiber? They say it's healthy, but we don't have any enzymes to digest it. 90% of the cells in the human body are not human cells. They are microbials. And gut is very rich, and the gut microbiome has the bacteria which has enzymes that can digest the fiber. And what happens when you digest the fiber? You have something called as short-chain fatty acids. There are other important molecules like polysaccharide A and peptidoglycan, but the key one is the short-chain fatty acid. Now, when you maintain a very sterile environment and too much of junk food with little fiber, you have less short-chain fatty acid. Why is it important? Because this is the only thing that can bind to GPR43. Every single cell in the human body has a GPR43. The only thing that binds to it is a short-chain fatty acid. And this is extremely critical for maintaining immune homeostasis. That's the reason why our diet is so important. So, of course, we need to establish birth cohort. I implore Neeraj to start one. And diet has potential, I believe, strongly to modulate the immune system. Intervention studies for primary prevention needs to be established. And very few countries in the world can do this. India should be the one to lead this. There are several other Indian studies, but none of these are community studies or based on schools. The next community study came from Neeraj, again in association with Ruchi Gupta. These are other Indian studies, all done in the clinic. Harish Babu, I was his PhD co-guide. He did a community study only for eggplant, but again, it was not a fully randomized control study like we did for the Europrevol. All the rest you see are all clinical studies. Pramod Nifarkar did a lot of work. Unfortunately, he is no more, but he did a fantastic work in the field of allergy. You had Mandal and Rajkumar, the oral food challenge. That's the gold standard. And the person with that experience is Dr. Rajkumar from VP Chest in Delhi. VP Chest is a place where you have a lot of these oral challenges have been done, and almost all data on oral challenge, double-blind placebo-controlled food challenge has come from Rajkumar from the VP Chest. These are all the Indian studies. Sorry, due to lack of time, I won't go into those. This is a summary. This is a review I wrote for clinical and experimental allergy. This looks at so many foods people are sensitized to. Okay, these are all the foods, and these are all the studies. They have done either skin prick test or they have done serum specific IgE. And each study, these are all the different foods in different prevalence rates. Now, this is again self-reported adverse reacts. This is from adults, again from community studies in India versus elsewhere. The only study in India in adults has come from me. These are all from other countries. Again, this is in children. Again, the community studies. The only one by the time we wrote review, I think Neeraj has presented recently. And these are all coming from the other countries in children. This is for the sensitization by skin prick test. Again, only community study. You will find is our data. And again, if you look at the overall prevalence of these Ig-mediated allergy from the community studies, these are all the overall prevalences. These are self-reported adverse reaction to food allergy. And this is the confirmed by skin prick test in children. This is the 8 most common foods. These are all the different countries. I don't have time to go into the details, but if anybody is interested, I can share the article. This is for some of the locally important foods. Like if you look at Hong Kong, they consume a lot of insect, eggplant, mango, chickpea, are all jackfruit, are all important in India. This is the paper from Neeraj. You can say that this is the second community study, but done from the school children. About 1,000 subjects were included, and out of 1,072, he had about 9 cases of which are suspected. Ruchi Gupta had developed an algorithm, so you ask a series of questions with which you are able to get it. And 9 out of 1,000, it's like 0.9%. It is still more than 0.1% that we found in children in Mysore and Bangalore. Maybe over a period of time, 0.11 has now become 0.9. It's still low compared to the Western. These are all the common foods, and these are all the common symptoms these people had. So in the I'm sure there are more talks. It's just a few points to highlight. History is the single most important thing. You need to have a temporal relationship, that is consumption of the food. Within 2 hours, there is a reaction. If you don't have that, really suspect whether the person actually has food allergy. It has to be consistent. Have you taken the food 10 times? Did you develop a reaction 10 times? If they say only 9 times, not 1, unlikely to be food allergy, unless it is dose related. 4 idli caused a reaction, 2 idli may not, but 5 idlis must definitely cause a reaction. We see children due to urda. Similar to any other food. Once a particular dose, there is a reaction. Less dose may not cause a reaction. Higher dose or same dose must cause a reaction. Food processing may be important, especially for heat labile allergens. Some pitfalls I quickly discuss. I know I'm crossing my time. I'll quickly go through. We have several misconceptions and misunderstandings, grandmother's theories, lot of foods are avoided, and it's a good work from Neeraj and team. There are no allergy departments in the medical college. We have a lot of self-styled, kind of allergies without much training and causing a lot of trouble with IgG, as Dr. Neelam just mentioned. So a positive test or serum-specific IgE indicates only sensitization, no allergy, please. Don't test indiscriminately. Don't test for 200 allergens. Food tolerate need not be tested. You can look for cross-reacting allergens with the pollens, so-called PFAS. Consider food intolerance when there's a strong history, but there's no IgE. Dose, manner of preparation, and ancillary factors, cofactors, may elicit the outcomes. So you need a good history. You need to know the dose, how it is processed, and cofactors, exercise, and all that. I'm sure you will have more talks on that. Ig binding to homologous proteins among food groups and between foods and pollens might have variable clinical relevance. Look for cross-reactivity. This is the cross-reactivity study with birch, which is not there in India except in the Himalayan part. But we had a lot of birch positive in South India as well. This is the cross-reactivity, quite high cross-reactivity. Again with the apple, celery, kiwi, peach, and with mugwort, again fairly high cross-reactivity. Peanut, you have most legumes, but the cross-reactivity is 5%. Tree nuts is about 35%, higher for this combination. Fish and other fish cross-reactivity 50%. Shellfish, other shellfish 75%. Grain, cereals, another grain 20%. Milk, goat, sheep is 90. Mare milk is 5%. Even with beef, some of these people react, it's about 10%. And serum skin test might be negative despite clinical reactivity. Then you have to do a fresh food prick by prick test can be done, or it is a non-Ig mediated allergic reaction. So increasingly high serum specific food Ig, increasingly large skin test or wheal size, they do not correlate with severity. You can have banana of 20 millimeter and the patient says, I eat banana every day, I have no problem. So it's quite possible. Therefore, it is very important. Take a proper history. Does he have multiple episodes? Then the chance becomes stronger to the same food. Anytime you have to ask this question, is a very leading question, but you must ask, was there any time you took the food and did not have a reaction? Very important to ask. What is the time elapsed between consumption and the food? Are you able to tolerate the same food in any other form? You need to ask. How is the food processed? Are you able to tolerate the food in lower doses? Is it triggered by the cofactors, exercise, painkillers, alcohol, so many other things? So between the skin prick test, history is most important. IgE, you find out skin prick test is a gold standard. It is very reserved for a very small group of patients, especially those who have severe food anaphylaxis. Even if they don't even come in contact with the food, that food is, if somebody is even handling it, they get a reaction, then it's better to go for a serum specific Ig. Thank you very much.
Thank you very much, sir. Excellent presentation as always. So what I understand that you are telling that food allergy is gradually becoming important for us and gradually becoming important for our country. And with the pace, the cases are increasing. And ma'am was saying that so many children, 45 million children we are having. That means definitely another 5 years or another 10 years down the line, this will be a bigger problem, at least in the numbers. So we need to be really aware. The other thing which you have told is about history is very important, and all the tests needs to be taken like a pinch of salt. And definitely skin prick test has an edge. So we will be discussing about tests more. So now we will moving to the next part of the presentation, which is about the sign and symptoms, gastrointestinal manifestations of food allergies, both IgE and non-IgE mediated. And this will be taken by Dr. Nishant Wadhwa. Dr. Nishant Wadhwa is senior consultant and chief at the Department of Pediatric Gastroenterology and Liver Transplant at Sir Gangaram Hospital, Delhi. Sir, we welcome you. Please share. Yes, sir. Please unmute yourself, sir.
Am I audible?
Yes, sir. You are audible, sir. You can start, please. Thank you.
Thank you. Uh, Thank you, Dr. Mahesh, for an informative lecture on the epidemiology and the wide variety with which allergies can actually present. My talk essentially would be regarding gastrointestinal manifestations of food allergies. And the commonest, as we all know, is the bovine milk protein allergy, which we as pediatricians come across, more so as pediatric gastroenterologists in our day-to-day practice. I thought because we are talking of clinical manifestations, I'll take you through some case scenarios as to how a pediatrician would come across a food allergic kid in his busy practice. Now, this is a case of a 3-month-old infant who had complaints of visible specks of blood with mucus for the past 7 days. And this particular child was exclusively breastfed, growing well. And as should be the case, he underwent a stool routine test, which showed pus cells full field and RBCs 20 per high power field. A test which could have been easily avoided, but was done in this child, was a culture which showed E. coli, and this child unfortunately received 2 courses of antibiotics, followed by parenteral antibiotics, no improvement, further investigations, normal, and the blood test showed only anemia. The rest of the tests were normal. Now, this is a classical case of allergic proctosigmoiditis caused due to bovine milk protein in the diet of the child. And where does it come from? It is essentially the bovine milk protein in the diet of the mother. And this is what results in the child having blood and mucus in the stool. The treatment is simple: to stop all animal milk products in the diet of the mother and continue breastfeeding. And whenever weaning is to be done, it should be using a dairy-free diet. Of course, needless to say that she would require calcium and vitamin D supplements because she needs to continue to feed the child. Now, should this child undergo a sigmoidoscopy, this is what shows up inside the rectum and the sigmoid of the child. These are aphthous ulcers, which on histopathology would show numerous eosinophils, essentially more than the number 6 per high power field. Now, bovine milk protein allergy is something I've taken as a reference standard for food allergies in children because that's where the story begins for most of the children. The incidence in exclusively breastfed infants is 0.5%. And this is, as I mentioned, due to cow's milk protein present in breast milk and the treatment I've already mentioned. Let's move on to another child, a 6-month-old infant with recurrent vomiting for the past 1 month. And this child has been treated with prokinetics, PPIs, antiemetics, and there has been no response. Now, one fine day, this child actually develops an episode of hematemesis and presents with a hemoglobin of 6.8, receives a PRBC. There is on history that the history of passage of mucus in stools, that the child was colicky, and there is essentially no failure to thrive. He's thriving well. On an upper GI endoscopy, which was done essentially to look for any other cause for bleed, it was essentially hemorrhagic gastritis with, again, eosinophils full field on histology in the lamina propria. The diagnosis, again, remains the same. And the treatment essentially also remains the same. And the stoppage of dairy in the diet of the child was all that was required. Now, this brings me to this question of adverse food reactions and how children present clinically with these reactions. And these reactions can be both immune and non-immune mediated, as we know. And in the immune-mediated food allergies, they can be both IgE and non-IgE mediated. And sometimes you can have both IgE, non-IgE causing the clinical symptoms. Cell-mediated food allergies essentially are allergic contact dermatitis. We look at the examples of each of these. One entity which stands out is definitely urticarial rash secondary to a food intake. But there's this mixed IgE and non-IgE mediated reactions, essentially representing eosinophilic esophagitis or eosinophilic enteropathy, duodenopathy, or colitis is something where you can actually look for these things. Now, these reactions, when we look at adverse food reactions, they can be both immune and non-immune mediated. And the non-immune mediated, you can have things like lactose intolerance and other things like hyperreactivities or food phobias. But when we look at the spectrum, the clinical spectrum of food allergy, on one hand is the immediate gastrointestinal reaction or oral allergy syndromes, which are essentially IgE mediated. And on the other end of the spectrum are non-IgE mediated reactions, which can in fact be as severe and sometimes more severe than IgE mediated reactions like food protein induced enterocolitis, FPIES. And there is a spectrum of disorders which actually falls in the middle, as I mentioned, which are essentially both IgE, non-IgE mediated, and eosinophils are found in various parts of the GI tract on investigations, being either esophagitis, gastritis, or gastroenterocolitis. We do know the common culprits or the common food-ate allergens, which are the big allergens, which we know cause most of the troubles, but as the numbers are actually increasing, and every day we do come across such rare entities, like sometimes, for example, in one of my patients, we found that the child was allergic to papaya, something which we had not thought of while he had characteristic symptoms. Now, this point was already discussed by Dr. Mahesh, that there are food allergen cross reactivities, and these cross reactivities can go across milk, beef, various animal products. Soya allergens can have cross reactivity with legumes, peanut allergies, fish allergies, tree nut allergies with other tree nuts. So these cross reactivities also confuse the picture many a times, because, as you know, the history is very important, and it is always the clinical manifestation uh, after the intake of a particular food allergen which should increase our suspicion towards a particular allergy. Now, there are various studies, and there are self-reported symptoms both by children and adults, and symptoms plus skin prick test or specific serum-specific IgEs. And as you can see, the self-reported symptoms are far more than when they are actually tested with these allergies or with food challenges. So the prevalence is to the tune of 3 to 12%. We are still in the process of gathering data for prevalence of food allergies in India. But then every food, when we talk of the GI tract, has its own story, and there are various hypotheses and explanations for these. The earlier a food allergy hits, the earlier it gets cured. So if a bovine milk protein allergy, as we know, is essentially a transient illness, whereas the subsequent food allergies like egg or peanuts, for example, or fish and seafood are some things which actually come across later part of the life, and most of the times the child is allergic to these things for the rest of their lives. Why is it so important when we talk of bovine milk protein allergy as a symptom complex in India? Because this is, as you can see, a very old study. And the reason I have actually quoted this is this was a hospital-based study. But as you can see, when it was just looking at etiology of malabsorption, and as you know, malabsorption is an important cause of malnutrition in our country. So bovine milk protein allergy came only second to persistent diarrhea, which, as we all know, is secondary to infectious causes, as the cause for, as an etiology for malabsorption in India. So you can see that it does have, in less than 2-year-old children, it is an important cause for malabsorption and hence malnutrition. It actually is far more common, was found to be far more common than even celiac disease or parasitosis as a cause for, or for that matter, any other illness as a cause for malabsorption. Later part of in the same departments, when these studies were conducted, and it was found that milk protein allergy was the second most common cause of chronic diarrhea in less than 3-year-olds, second only to celiac. And I'm talking for a study from Lucknow, India, in SGPGI. And it was far more common than IBD or even infectious causes like Giardia. So when we talk of clinical manifestations of both IgE and non-IgE mediated uh, allergies, we find that if we take milk as a prototype, we find these are the usual body systems which can get affected. But after the intake of bovine milk, which could be cow, buffaloes, goat, or any other animal milk, it could be an oral tract involvement in the form of itching, redness of mouth and lips, or a respiratory tract involvement with rhinitis, asthma, and wheezing, or a skin involvement with dryness, urticaria, atopic dermatitis, or angioedema, and gastrointestinal manifestations of vomiting, abdominal pain, symptoms akin to reflux, or with or without a prolonged diarrhea, chronic diarrhea leading to malnutrition. So, so essentially, the child can actually present for the first time to a dermatologist or a pediatric gastroenterologist or an allergic specialist, and the diagnosis should sometimes lead you to the common diagnosis of a milk protein allergy. We do know that 15 to 20% of children with suggested or proven GERD, gastroesophageal reflux disease, and CMP suffer from both the conditions, which means there is an overlap. And this has definitely led to the guidelines asking for abstinence of milk, bovine milk in the diet of children who have been proven good for at least 2 weeks to see whether that is one of the culprits. None of the tests prove or disapprove the diagnosis of milk protein allergy, and hence one has to have a careful history and the history of intake of such a milk. And elimination diet and rechallenge remains the gold standard. Uh, Very rarely would require later on skin prick test to ascertain whether or not milk can be added, only in severe, very severe cases. Most of these children would do well with dairy-free diet, both for child and mother, for 4 to 6 weeks. And if there is an improvement, a re-challenge can be done after no earlier than 2 months. If the symptoms recur, it confirms the diagnosis, and a re-challenge then further can be done beyond the first per day. In India, we have various options for treating these children, and essentially these are extensively or partially hydrolyzed formulas, which are now easily available. Prior to their availability, we would rely on soya formulas, very well knowing that 3 to 4% of children would react to soya as well. But then in those days, we didn't have the options. And sometimes we had to go for non-dairy feeds. Now, since I'm on the topic of clinical manifestations, it's pertinent for the information of all the pediatricians across a country that we as pediatricians have been trained to pick lactose intolerance far more common than bovine milk protein allergy. And there are certain differences between these two entities which are of importance, because one is an allergic immunological reaction, the other is a non-immunological, as I mentioned earlier, non-immunological reaction to lactose. And because it's an immunological reaction, milk protein allergy is qualitative. It's an all or none phenomena, while lactose intolerance, the response is based on the amount of lactose intake. So while you can actually prescribe curd to a child who is lactose intolerant, you cannot do so to a child who is bovine milk protein allergic, because he can have severe reaction. The organ involvement is in lactose intolerance essentially GIT, and usually presenting with small bowel diarrhea, flatulence, and perineal excoriation, while milk protein allergy, as I mentioned earlier, was due to these ulcerations in the gut, which are the culprits, leading to a large bowel diarrhea, tenesmus, blood and mucus in stool, and sometimes symptoms very much mimicking GERD. The infancy and toddler group, infancy essentially is the age group when you find both of these diseases, but lactose intolerance can be present in the older age group as well. The point I want to highlight is that while you are prescribing low lactose diets in children with lactose intolerance, please don't do so in children with bovine milk protein allergy. Now, while we are talking about wheat food allergies, it's important to talk about an entity, wheat allergy, which is an IgE mediated and not gluten intolerance, as we all know celiac disease is. And this entity is not a lifelong one either, and it resolutes by usually by age 12, and the median age of resolution is 6.5 years. We all know that wheat-related diseases have a spectrum, right from celiac disease to wheat allergy, which is IgE-based, to non-celiac gluten sensitivity. And while we are talking of allergy per se, which can be both IgE, non-IgE mediated, and the principles of picking up this allergy, as I mentioned and was mentioned in the previous talk, is based on the clinical symptoms with supportive evidence being gathered with various tests, as was mentioned. We do know that celiac disease is a total separate entity. One should not confuse it with pure wheat allergy, which is far rarer than celiac disease, at least in the northern part of India, which is diagnosed only on histology, where IgE for wheat is usually negative. But having said that, you will have lots of patients of non-celiac gluten sensitivity, essentially people who are like reporting themselves to have symptoms, clinical symptoms, and symptomatology after eating wheat. And we usually find that most of these tests are negative for these children, while they do respond beautifully to gluten-free diet as well. So detailed history is very important, and you can have cross reactivities with other entities. So a detailed history becomes even more important. And it's important that when testings are being done for these children, when you have a suggestive history, then one has to look for both cooked and uncooked food reactivities. There are various, I'm sure these tests would be discussed later on in the subsequent lectures. There are both positives and negatives associated with each of these tests, pros and cons of many of these tests, and double-blind placebo-controlled challenge still remains gold standard in picking up a allergy. Now, there is a positive predictive value associated with the various IgEs, but then just IgE values do not matter while making a diagnosis, clinical diagnosis of food allergy. It is essentially and will always remain a clinical diagnosis based on history and examination, and of course, corroborated with various tests. Just getting blood tests done and finding positivity to various food allergens usually means nothing. And that is why it is important that there should have a likelihood of allergy from history, which could be a high, intermediate, or low, which can be corroborated with uh, allergy due to specific Ig levels. And when you actually combine the two, that is when you reach a diagnosis of allergy, a probable allergy, or a possible allergy. But as we know, the dietary habits of Indians are changing, and with increasing development and the nutrition and the diet of the children, Indian children, we are actually copying the West, and hence the disorders of allergies are also on the rise. And I think we are looking at far more allergic disorders now, GI symptoms with allergic disorders, far more than we did 10 to 15 years ago. So to conclude, well, as was mentioned with Dr. Mahesh, and I'm repeating it, there it is a reality, and it is surrounded with a lot of myth, and these myths are due to ignorance. And once we have more scientific data, and I would talk about more tangible scientific data from our own country, I think our belief systems into the presence of food allergies and their management would become better. But then there is a lot of overdiagnosis is happening, as was mentioned earlier, and we should be very particular about our clinical history in these children with GI symptoms. So you can have symptomatology right from the upper GI tract to the lower GI tract, both small bowel diarrhea, vomiting, to large bowel diarrhea, tenesmus and enterocolitis, proctosigmoiditis, and leading to these kind of allergies. When corroborated with the timing of intake of these food items is what one should look after. And once these two are together present, only then can a tangible diagnosis of a particular food allergy in a child can be made. So it can present with both gastrointestinal, respiratory, and skin manifestations. The first manifestations, as I mentioned, for food allergy start in infancy when milk is introduced, bovine milk. It is the commonest food allergy worldwide. So vomiting, GI bleed, diarrhea, and of course, vague abdominal symptoms akin to IBS have also been reported in older children with food allergies. One does need a high index of suspicion in areas which are endemic for GI infections, because more often than not, GI infections have been implicated in these children again and again, and they end up having lots of antibiotics before they are diagnosed with food allergies. And I would just end my presentation with this famous quote that give me neither poverty nor riches, but feed me with food convenient for me, because this food is going to last forever and lead to longevity and good health for human beings across the world. Thank you so much.
Thank you, sir. Excellent presentation. And please stay with us for the question answer sessions till the end of the webinar. And now, as Dr. Nishant and Dr. Mahesh has stressed so much about history, and after taking a good history, we need to really investigate in certain situations. So we will move towards investigations. But before moving towards investigation, I would like to introduce a very wonderful person, Dr. Sai Nimagada. Dr. Sai Nimagada is, to me, he is more like a friend. He is more like a elder brother to me, and he is a famous board certified allergist from Chicago. He is from Center for Food Allergy and Asthma Research. So first of all, Sai, welcome you on this platform. Thank you for joining us. And I would like to thank you and Ruchi, both of you, to allow us to join hands together with CFAR So I would like to have your words, few words of blessings to all our listeners from CFAR on behalf of CFAR.
Well, Niraj, it's always a pleasure to do these presentations with you. And I look at you as almost being like the father of allergy in India. You've taken the specialty and you've really grown it. You've become very passionate for the education of allergists in India. You've had these wonderful seminars, and hopefully we'll be able to join you guys in person in October. Although we need to rearrange a few things, but your energy and your passion, and when you came here last year to CFAR, or last year, the year before, I believe you gave several nice presentations, and your dedication and your knowledge in this space, especially in the Indian community and the worldwide issues that are arising from food allergies, has been very moving for us here at CFAR. And so, our collaboration with you, and also I see Maha's on the line as well. The collaboration that we continue to have, looking at the Indian allergy studies that we've published as well. We just got recently, I think, our global food, or we just got a publication in Jackie Global, I think, for our Indian studies. So again, you are a great friend. You're a great mentor to me. I've learned so much from you just the last couple of years and partnering with you. So I thank you again for having us speak at these conferences. And again, I feel like my talk is so basic, but you have a nice presentation overview of everything that you're doing here. So again, we're very thankful to be able to participate.
Thank you, Sai. Thank you. So Sai is a wonderful allergist, I would say, that I would have found at Chicago. So he is going to take us through investigations in food allergy, both in vitro and in vivo. Sai, please share your slides.
All right, let me see if I can share the screen. Let me get my presentation up, and then let me see if I can do this here. All right. And then we are going to do presentation mode. And then how do I share off the presentation mode? Okay, here we go. Let me get back here again. Let me share it first, and then we can go presentation mode. Okay, share. Now, what do you guys see?
We are able to see your screen in which Zoom is written.
Okay. All right. Let me pull up diagnosis management.
Yes, we can see your slides now. Please go on the slideshow.
There we go. All right. So, like I said, that Niraj, I feel like I'm giving such a basic talk, but I think that there's a lot that goes into the investigations of food allergy and all. When we talk about potential steps for diagnosis and management, the biggest step I think is taking that critical history. When we are talking about that, taking the clinical history, and then from that ascertaining different testing, foods that we're going to test or different tests that we're going to run, and then looking at either the specific skin testing or potential IgE specific allergy IgE testing. And then of course, the gold standard, of course, would be the, oral food challenges, and then other, up and coming modalities there. And then once we diagnose a food allergy, of course, it's by elimination diet, and of course, equipping the family with the treatment measures and so forth like that. So when I'm taking a look at establishing a history, most of the time, 1 in 5 patients that I see come into my clinic and they don't have a food allergy. They've been tested by panels, and what I mean by that is, primary care as well as some specialists. They'll take a phone history, then they'll run a panel, and what ends up being is you end up getting into trouble. And my advice is never to order a generalized panel, especially in kids with infants with mild eczema, and only confirm and test what is really meaningful from the clinical history. And you don't want families to avoid unnecessary foods, because it really does lead to psychological impact and so forth, trying to travel and school settings and all these kind of issues that come up, especially with anxiety and so forth with the family. So again, over testing is rampant. As as the running joke I always have is like, these over testing has put my kids through college here. So in one way I say, don't over test, but in the other way, it does keep me very busy. But it'd be nice to be able to see some of the kids that really truly have food allergies overall. And the biggest thing that the big misconception, the biggest faults that I see is especially with primary care and also specialists is like, what does a convincing reaction look like? And you'll know it when you see it. It's sort of like, when you come across, convincing food allergy history, you'll see it. I always say look for what a convincing reaction is. If it's two or more, the following is present, especially cutaneous skin reactions, respiratory, persistent rubbing of the nose. That's consistent with the food exposure. I just saw a patient literally 2 minutes ago. Came in and the mom says in daycare they're being sent home with all these, generalized rashes and, some intermittent, urticaria, but the kid is able to eat Go-Gurt and milk in some forms, but then they avoid other forms. So to me, it wasn't very convincing, at least the consistency of those reactions there. Gastrointestinal, sudden onset, high volume diarrhea from the previous speaker talking about lactose intolerance and also milk protein intolerance. These things can be an issue, and also there's things that we also don't think about all the time, but the FPIES reactions, and now we're starting to see a lot more of that, and especially the delayed, up to 2 hours or 4 hours afterwards, the sudden onset vomiting, and then you get a large volume diarrhea with that there. Typically, we see, cutaneous, reactions, of course, and then the shortness of breath and coughing and wheezing, and then swelling of lips and tongue, dizziness. Those are all classic symptoms of an allergic reaction. These are a little bit more definitive. All right. So if you see these, you can probably presume that if the timing is consistent, that there was a food reaction that's noted there. The call comes in. The key questioning, of course, is the timing, reproducibility, clinical findings, and actions, and then what happened next. These are all consistency, and I do this with every single food. If parents had a dinner event and they had let's say they had some exposure to nuts, and they also had some fish and shellfish at the same time. Sometimes these things come up, and so we had a kid in our can-do study that had egg, milk, and sesame all at the same, and also peanut all at the same feeding. So we're trying to figure it out. And they've had multiple times that they've had these foods, and it ended up being the peanut was the one that we actually skin tested and was consistent with that. Even though they had previous foods numerous other times, we ended up just testing them just to make sure that there was no clinical sensitization to those foods. Once the diagnosis established through clinical history, only confirm those likely to cause the reaction, not out of curiosity, even though I'm guilty of it as well. All these other foods. I'm like, all right, I'm praying that they're going to be negative, and most of the time they usually are negative. But there may be a few times that they come up positive, and then now you're stuck. Now you got to do a food challenge, or you got to convince the parents to go ahead and introduce the foods, even though you clinically think that the kid does not have a food reaction there. So diagnosing a food allergy, there's a difference between sensitization and allergy. Sensitization is just the presence of an antibody or protein against the food. And this can be detected by a skin test or blood test. Positive tests alone do not indicate an allergy. And this is something that I've always tried to educate, our referring physicians. If you have a positive skin test, positive allergy, then it doesn't necessarily always indicate that. And Maha's probably seen these cases, and I've seen these cases too, where the kid's peanut is over 100. You would put any amount of money on that kid that would not be able to tolerate peanut, but they are out there. There's significant positive reactions above the 95th percentile of clinical reactivity where we see the kids are tolerating it. And what I tell parents to do there is absolutely do not stop that food at any cost. If anything, I'm actually feeding the frequency a little bit more in some of those kids. And tolerant individuals can test positive, especially after they outgrow the allergy. So even though they've had a milk and egg allergy, they're going to test positive for 6 months to 2 or 3 years even afterwards. So again, there's like a high rate sensitization there. So a food allergy test, getting to the meat of the talk here, is basically allergen-specific IgE, skin prick testing, and then of course oral food challenges would be the gold standard that to rule in or rule out a food allergy with that there. The skin prick test is commonly the most easiest thing to do, quickest test that we have that comes back with results. And what we typically do is we place an allergen or the food in question. We can do a prick sometimes, and where we actually, like, for example, avocado, or like guava. I've got a lot of patients allergic to kiwi all of a sudden. So we bring in a fresh kiwi, put a drop of the kiwi juice on the skin, and then we just use a piece of plastic, lancet. We then scratch test the patient there. So again, it's called a scratch test. We're not necessarily trying to draw blood here, but we're just just slightly piercing the epidermal layer of the skin, and then based upon the reaction there, within 15-20 minutes, you'll either see an urticaria or hive, or you'll end up seeing no reaction at all. Again, what we must be careful about is the dermatographism. So kids that will react to this. So what we consider as being a positive skin test is usually 3 millimeters greater than the negative control. So 3 millimeters and up. So if the kid is dermatographic, has a 4 or 5 millimeter, saline test, then we consider 7 millimeters or greater to be the clinical reactivity for that particular food. Now, the skin test can vary from negative to 8 to 10 millimeters to pseudopods, where I consider they have like outpouchings. You can't really draw a complete oval circle. I measure the wheal mainly, but the flare is also sometimes, to me, very meaningful, even though a lot of clinicians don't always consider the flare as being, significant. I think that sometimes the wheal flare ratios, sometimes, there's some times where I won't do a food challenge because the wheal is like 8 to 10 millimeters in a peanut, and the flare is just even like 30, 40 millimeters. I'm like, the kid is definitely reacting, sequentially to, degranulation of mast cells in the skin. Or if I do a food challenge, then I'll go ahead and I'll do like a 4 or 6 dose challenge, or a 6 dose challenge instead of a 4 dose challenge with that there. It's considered safe. I've been doing this for 34 years now, and I've, knock on wood here, I've never had a kid react to a skin prick test, although I've had historical kids that have seen me for that there. So false positive rates are high. If you are skin test positive, it's 50-50. 50% of the time you're not allergic to the food, 50% of the time you are. But if you're negative, it's 90% certain you don't have the allergy. Again, 90%. I had a kid that tested twice negative to egg, immunologically barely reactive to egg. I told him to go home and try the egg at home. Anaphylaxis. Of course, the mom fed like 2 eggs or 3 eggs. Anaphylaxis, ER, 911, hypotensive. These things happen. So there's nothing that's infallible here. And matter of fact, this kid's reaction was just like a month ago. So I was quite surprised, but try to see what I missed. And I don't think I missed much, but somewhere along the line, some of these tests were not necessarily convincing with that there. So, so when we talk about what to do next, this is our seed algorithm that we have here. So the seed algorithm is we continue to take a look at the open reactions there. If they're under 2 millimeters, then we could go ahead and test, or just feed it to them. If they're 8 to 10 millimeters, we'll bring them in for additional testing, oral food challenges there. So it's a pretty detailed algorithm, and Neeraj is familiar with our CAN-DO early intervention trial that we're doing there. Now, food-specific IgE, it's coming to be more of a clinical standard for us here, and there is, different differences between foods. I know that we've done, some food-specific IgE studies in India with Priyanka and also Neeraj, and we've had all these different foods with different immunocap levels and variability. I think Priyanka skin tested over 140 different allergens. I'm like, where did you find 140 different allergens? But apparently they are available widely in India, which I was, not, it's hard to say what is considered, truly predictive as far as immunocaps go. But at least for the 95th percentile positivity and 50th percentile negativity, we're taking a look at peanuts over 14, milk is over 5. If you're under the age of 2, then it's going to be 5. If you're over the age of 2, it's 15. And then egg, of course, if you're under the age of 2, it's 2 or less, or 2 or more. And then if you're over the age of 2, then it's 7, or sort of like that. And then again, if you compare the skin prick test wise, you see that about 7 to 8 millimeters here. And especially with wheat and all, wheat is one I remember, wheat can be over 40 or 50, and it could still be negative there. So we've gotten to learn about food allergy component testing, and this is, component resolved diagnostics. And what we're taking a look at here is specifically taking a look at the proteins that make up these foods. Like the peanut may have like 6 different proteins that we're looking for, and milk has got 3 different, and egg has got 3 different food allergy components as well. And the food allergy testing is highly sensitive and only moderately specific here. So sensitivity is over 90%, but specificity is only 50% there. And if you don't have a clinical reactivity, then the positive predictive value is less than 50%. And they can add, a significant amount of information, especially with some of these the peanut, especially peanut, milk, and egg, mainly the ones that we are taking a look at here. And you can see some of the tree nuts as well, the different component resolved diagnostics that we have. With cashew, the ANO3, and the hazelnut, the core A1, 9, 14, sugar 1 and 3, and sesame and the wheat. And we're going to go through these a little bit pretty quickly here, but not everyone needs component testing. I always say don't order the components if you got a convincing history and there is a high specific IgE. You're probably going to be okay with just that. But if you have a lower specific IgE and you want to see if there's a chance to tolerate unbaked cow's milk or even a lightly cooked egg or baked egg, it may be very helpful there. The clinical reaction and the atopic comorbidities are still the most important factors on who decides needs component testing there. For cow's milk, it's casein and then whey. It's degraded by heat. 80%, if allergic to cow's milk, avoid all other mammalian milk. Again, high cross sensitivity to both goat and sheep. And then, of course, the casein is approximately 90% of that there. The hen's egg, of course, is the ovomucoid is what we look at for the baked egg component. These sometimes gets degenerated, and ovomucoid is heat stable. So if you have a high ovomucoid, then you most likely need to be cautious about looking at the baked egg or the egg ladders or the milk ladders there. One word about milk ladders is they're not without potential risk. I think there's been two reported fatalities with milk ladders. So again, milk and egg, it's tricky. I've seen milk be a lot more tricky than the egg. So be very careful about introducing milk ladders in some of your patients, especially on the home setting, potential or possibility with that. When we talk about baked egg and baked milk challenges, again, if the skin test in our prick skin test is under 10, if the ovomucoid is under 10, consider baked egg. And then baked for the baked milk, if casein is under 5, or the skin test is under 10 millimeters, you can consider a baked milk challenge as well. Peanut components, of course, are mainly RH1, 2, and 3. 6 in the European countries are starting to react, and also 8 and 9 are mainly more lipid transfer proteins and so forth like that. Tree nuts, again, most patients are sensitized to 5 or 6 tree nuts, but most are only allergic to 1 or 2 tree nuts. So when we talk about, the sensitization versus cross-reactivity there, walnut and pecan, same family. Cashew and pistachio, same family. If you're pecan allergic, you're 100% walnut allergic. If you're pistachio allergic, you're 100% cashew allergic. But we do have patients that can tolerate walnut and cashews occasionally, or pecan and pistachio at times. So there are some patients that it's worthwhile to do those oral food challenges for them with that there. And again, the walnut components are the Jugar1 and Jugar3, and then cashew's ANO3, and then the hazelnut is mainly 9 and 14. If these are reactive and positive, then be very cautious about doing any oral food challenges there. Of course, the gold standard, of course, is the oral food challenge. The problematic is you got to bring them in. It's time consuming. There's like issues with the family. If they do react, then you have treatment issues. And then sometimes you have post-traumatic stress disorder with these food challenges. So only do this when needed, and I only do it if I have a more than 50% chance passing possibility, or if we want to start OIT and start to see if there's any clinical dose reactivity with that there. Again, when to refer out allergy testing, taking a look at environmental control instructions there, and especially with the oral food challenges would be the time to reach out to a specialist. New and emerging diagnostic modalities. I think that you have a talk coming up about this, but I thought I'd cover this a little bit. But the basophil activation test, I consider this a food allergy in a test tube, food challenge in a test tube. And then, of course, epitope mapping, and epitope eliminates the biological noise associated with the peanut, especially specific IgE. And we are starting to get epitopes to both milk and egg, and also tree nuts there. The basophil activation test really is just you're taking the patient's blood, you're adding it to the allergen antibody, then you lyse the RBC, then you do flow cytometry, and you're looking for activated basophils, which would be the CD63 component there. And based on that, you can then determine whether or not these different basophil activation percentages of CD3, or CD63 positive cells that have been activated. And so there's been a wide amount of publications associated with basophil activation. It is getting there. We are getting near to there. And CFAR is going to be participating in a COFAR study, which is a consortium of food allergy and asthma research, or food allergy research at the NIH funded study. And we're going to be doing BAT, and we're going to be doing TOOL, we're going to be doing flow metrics on the skin, and then vasodilatation. We're also going to be doing diastolic and blood pressure. We're trying to find a surrogate that can not take out oral food challenges. And I think BAT's got a chance, basophil activation test. There's also mast cell activation test too, which is MAT as well, which has also got a potential for this as well. And the pitfalls of BAT, of course, it's you got to process the blood right away. You can't store it, and that's one of the major issues there. And then there's also a large degree of variability that we see. And the other diagnostic challenge, of course, would be the allergenist test or peanut epitope matching. And Jessica Palmieri has been involved with this a lot. She's got a publication that just recently accepted here. And basically, what it is we're taking a look at the different RH2 epitopes, and the RH2008 and RH2009 appear to be the epitopes that appear to have the highest clinical sensitivity for allergic reaction there. So now you can do this epitope mapping and then determine what type of reactivity levels you're going to have with your patients. If it's going to be high, moderate, or low sensitization there. So if they're very highly reactive, then they'll tolerate more than 144 milligrams, 30% only. If they're moderate, then 60% will tolerate more than 144 milligrams. And if they're low reactivity, then 80% of them. So it gives you a little bit of an idea about where to start your OIT, what your clinical reactivity is, and also whether or not you need to avoid cross-contaminated foods and so forth like that. So epitope testing is actually coming of age, and I believe that it will be more adopted as we start to get more data on this as well. So again, in summary, oral food challenge is gold standard. Skin prick test and specific IGs still have pitfalls than existing tests for oral food challenges in a test tube, basophil activation tests, and then allergenist and epitope mapping there. So with that there, I will leave it back to Neeraj and your group. Hopefully I was on time. I tried to go through this pretty quickly. I didn't know how much time I had, but hopefully we stayed on time a little bit here. Thank you, guys.
I think you were really perfect, and you have really delivered whatever I was expecting. You were beyond that. You have actually put up something different, which is epitope. I will come into the questions related to epitope to you in the question answer session after Maha's talk. So
Sure.
I think there was an interesting fact which Dr. Mahesh narrated, that actually 90% of our body is basically microbiota. It is only 10% which we are having our own body. So I really don't know whether it is our own body or it is something which is, you can say, like we are on rent to microbiota or to microbiomes. So we always say that it is not ourselves. It is like our body is on the rent. So I think this puzzle is going to be solved by Maha. So Maha, welcome and thank you very much for joining us. So Dr. Mahadevnia, she is Professor in Chief of Division of Allergy and Immunology at Rush University, Chicago, and she has done extensive work on microbiota across the globe. So I welcome you, Maha. So thank you very much for joining us, and please share your screen.
All right. Hi, everybody, and thank you very much both for the kind introduction and the invitation. All right, so with that, let's jump to this. So the microbiome in food allergy has now been a subject that me and many others have been studying for a while.
Maha, sorry.
And
Maha, sorry, your slides are on the presenter mode. So can you go on the, it means like, yes, slideshow or something?
Let me see. I thought I was back. Presenter mode. I knew how I would. Let me just stay on that.
Oh. You can go in the display settings. Yeah, you can go from here to the slideshow. Try slideshow.
Hello, slideshow and my slideshow. As it still goes to the presenter mode, right?
Okay, we are okay with this. You can continue. Okay, we are okay with it. No problem. Yeah, please continue.
Okay. Yeah. Thank you. All right, so let's touch base on some of the data, the newest data on what we know in microbiome and food allergy. So I like always to try to put things in a figure. And this is how today we think of the role of gut microbiome in food allergy. So there are many factors that we have studied over time and we know does impact allergic diseases in general, but specifically food allergy too. A big one is diet. The other ones are multiple environmental factors like the deprivation, the pollution, violence, education, green space, food access, all of these multiple studies are showing it does impact food allergy. And there are also patient-specific characteristics. All these three factors could actually impact the gut microbiome. And we believe nowadays that gut microbiome might be a pathway of how certain environmental factors or even patient characteristics can result in an allergic outcome, including food allergy. So I'm going to try to touch base on all these three and how they could result in food allergy development or its outcome through their impact on the microbiome. Before getting to that, let's just talk about how we even came up with the idea, and all that goes back to the hygiene hypothesis. So now that it's like 1980s, this was put forward that the good microbes are protective against allergic diseases. And later on, we understood that the protective effect of living in a farm against development of allergy, which has been known, is actually driven by the microbes. So we do need a healthy microbiome in our cell system, which is dependent on how the individual's exposed to the environment around it. So living in an enriched environment that's full of microbes is important for us to develop the good microbes within us, and they can then help to prevent allergic disease. So I'll just jump to a couple of studies. The first study I'm going to talk about is a study that comes from African population. So although the prevalence of allergic and atopic diseases is much lower in Africa, the individuals who are originally from Africa but have been for generations living in Western societies actually are significantly at higher risk for not development but also poor outcomes. So that creates actually now a good specimen for us to understand why, as a human being, because we are all born in Africa, this is our origin. We are, as when we move to another continent or environment, all of a sudden we start suffering from allergic diseases that originally in our country of origin, we were sort of protected from that. For that, we compared actually samples from two different areas in South Africa. Cape Town is a modern city similar to many cities in Western areas, and also a lot of modern cities in India now, versus areas in West Cape that are completely rural, people really living in nature with very minimal, actually, modernization of life in any aspect of it. So this gives us, if you go back to the diagram, a opportunity to start and study the diet in these individuals. So not only where they live is different, what they eat is different. So these children are mainly eating fresh fruits or the foods that are just coming from the farms that they're raised in, and they're prepared with very minimal amount of the preservatives or anything that will make the food different from what it should look like. Versus the figure on the right, so the kids, majority of the kids, unfortunately, living in modern cities, this is their daily staple that really does not look like food anymore. You cannot understand what has gone to that food, highly processed, and a lot of industrialization in preparing those. So, and we know that the diet is actually the most important drive of the human microbiome. So the neonatal period, babies are born with a lot of proteobacteria. As they go through infancy, the milk fermenters go up, and then once they start eating table food into childhood, the microbiome starts changing, and really the introduction of the solid food is the one that dramatically changes the gut microbiome into the adult microbiome. Okay, so going back to the study, Black South African children from the remote or rural area were included in this study, and there were some children that had already developed atopic dermatitis. All the kids were tested for food sensitization, and then we had controls of the same children who had none of the atopic diseases or food sensitization. Gut microbiome, as expected, was dramatically different in children. So these are completely unified in terms of genetics, same group of children who had moved to Cape Town and were living there, so same tribe, however, just living in, being raised in different environment. The diversity of gut microbiome was drastically different. And these are really, really different. This is not only the alpha diversity, meaning the number of the species overall, or the richness and evenness of the gut microbiome was significantly higher in the children living in rural area, but also as a community, there were different types of bacteria in the two groups. Next, we actually implemented the atopic dermatitis. So these are the children who had food sensitization or lived in different environment. And as you can see, the four groups completely differ in that section too. The food sensitization was significantly higher in Cape Town children. And it seems that it is driven really by the, as you can see, so these are the, if you look at it, the urban controls and the urban AD. Urban, these are the children who have developed atopic dermatitis and are food sensitized, completely different from the ones that are living in rural area and do not have any sensitization. So this is showing that the community of bacteria is playing a role in this. So the next was, now let's dig into their diet. So the important thing was that the high sugar intake in these children was associated with decreased diversity of gut microbiome. And the result was so significant that we understood that the main factor that was actually decreasing the diversity of gut microbiome early on in toddlers is how much added sugar was in their diet. Furthermore, high saturated fat intake was associated with decreased some of the good gatekeeping bacteria. So the rural gut microbiome is more diverse, and it has more P. copri, which is a gatekeeping good microbiome. And it's shown that majority of this effect is driven by what the kids in Cape Town are eating, that those in rural area are not, and that's added sugar and added saturated fat. So here what we're showing is that the diet, as I just showed you, really is dependent. So high fat and high sugar diet versus mainly vegetables and less added sugar can impact not only one important gatekeeping bacteria, but the total diversity of gut microbiome. And that in turn can increase the allergen exposure and barrier dysfunction, which other studies have shown these bacteria are important. So diet is definitely a big factor here, driven by gut microbiome. Next, let's look at evidence on other environmental factors. So for that, when we wanted to study, we said, okay, so what's in the modern house that's very different than in rural living? And a simple way to look at that is the house dust. So we actually looked at a couple of things, roll off the pollution in the air, and then what's in the house dust inside the home. So majority of the modern houses are constantly being cleaned with different types of detergents and germicidals on all the surfaces, versus rural living, the majority of the houses are actually built from clay, There's still a lot of exposure from the outside. They're coming inside. It sets. Whatever people eat from are stored in the same spaces. So they would be a lot of exposure to the bacteria that is here that's pretty much coming from outside to the gut. So for that, we said, okay, we're going to sample dust from the areas that the child sleeps and also from the areas that they spend most of the day, and then compare those in a rural versus urban home. And as expected, the dust microbiome was so different, it had almost no overlap. So the completely different type of bacteria in the gut of children starts colonizing when they are living in an urban house. Also, when you look at the diversity, alpha diversity, the evenness and richness, all of those significantly decrease. And decreasing those is never a good sign in a child. So we also found that there is a higher relevance of certain microbiomes like Ruminococci, Lactobacillus, and Bacteriaceae in the rural compared to urban. And all these three groups are very important to colonize the gut early on because they're protective against development of allergy diseases. So we are showing that important gatekeeping bacteria that are in the house dust, they are needed in the environment, are decreased in children living in Cape Town for this. And also we had samples from US homes. So the important bacteria in the house has decreased. And that was associated with less bacterial diversity in the gut of the child. And also at the side study, we showed these bacteria were associated with less atopy and Vs. So it's not just food allergy, but this decreased bacterial diversity, again, results in allergen exposure, barrier dysfunction, development of asthma, eczema, and food allergy. So not only what we eat is important, but where we live and how exposed to microbes in the environment is important. Okay. The next study was comparing now a large group of children from Cape Town to those in Chicago. So unfortunately, the living situation of the lot of African American children living in Chicago is not optimal. So they live in houses, although there's dirt, but the dirt around it does not have the fortified natural dirt that has been exposed to nature. So this is really industrial dirt that's shown not to have the bacteria needed. So we were curious to look at the gut microbiome of these three groups of children. So first, the African American, they're in the red group. As you can see, the diversity is dramatically lower than the rural children. It's similar to the Cape Town children, which we sort of expected, because if you look at the structure of the cities, in a way, although Cape Town's a lovely semi-mountainous city, the structure of the modernization of cities is similar to cities in the US. And then when we looked at, okay, let's see what are the important bacteria that are missing, we found few of very important gut microbiome gatekeeping bacteria that were decreased. And I'm showing you Prevotella copri because this now we know is actually a very important keeper of the immune system that almost undetectable in children from Chicago. All right, so they had decreased, and importantly, the children in Chicago had a significantly higher rate of asthma, allergic rhinitis, and food sensitization compared to those from South Africa. The next study I'm going to talk about is actually results from our forward study. So this is a large prospective cohort. Every child in this study has food allergy. So we had sampled their gut microbiome, and then we looked at that in terms of, so there were 152 stool samples. We analyzed this one with shotgun analysis. So this is now like more advanced microbiome studies. And we wanted to know within the children who have food allergy, presence of another atopic disease, so asthma, for example, was that associated with a differential microbiome. And as you can see, you could see definitely there were decrease in some good gatekeeping bacteria in those who had asthma, and there were increase in certain bacteroides that are known to cause asthma among children with food allergy. So even if they have started the atopic march, these kids, all of them have food allergy, what is in their gut still matters, because that will sort of result in further advancement of the atopic march, development of respiratory diseases, even among these children. And when we compare the Black versus white children in our group, we also showed that the same Bacteroides families, unfortunately, are higher in African American children, and some of the important bacteria, good bacteria like Bifidobacterium, are decreased in Black children. And that might be why we see that Black children in US have significantly worse outcomes compared to white children. And this is showing it a little more elaborate. So when we looked at it, we understood that the Clostridia bacteria, again, Lactobacillus and Ruminococcus and Veillonella, are decreased in asthma and AD. P. copri was definitely, again, found and was reduced in asthma. We know that bacteria is supposed to protect against asthma. And then asthma and eczema are linked to lower relative abundance of several Bacteroides species in this group of children with food allergy. Okay, so sort of the diagrams now completed. I showed you some results on the diet, a couple of results from the environment, like the dust microbiome, and some on the African American versus white. So we know that their gut microbiome is now impacted, so patient characteristics. So diet rich in simple sugar and saturated fat is bad. Lower abundance of protective bacteria in the house dust could be detrimental. So it's important what is in the house dust. And the lower diversity of gut microbiome is associated with food allergy that's seen in atopic diseases. Okay, with that, I'm going to talk a little bit about having exposure to animals, because more and more data is coming that this might be one way of protecting children. So there are few good studies. I've summarized two of them that have shown, as you can see, having any pet inside home is protective for food allergy. Dogs that's kept indoors definitely are protective, but if the dog is completely outdoor and does not have any access in home, is not useful. Even for cats that are notorious because we know that they are associated with wheezing and especially early on, and if the child is sensitized can have a problem, but having a cat that comes inside is protective against development of food allergy. And this is a very, very large cohort study that showed that to us. So there's the next set of studies, including one of us, that we showed that pet exposure changes the house dust microbiome. If you remember, I showed you it's very important what's in the dust in the house. And the pet exposure increases the abundance of the two most important bacteria, Ruminococcus and Oscillosporia. So they sort of bring them inside the home, and then there's a chance for them to develop as part of the gut microbiome. And pet ownership increases the endotoxin levels at home, which in certain time points in life is actually protective against allergic sensitization. There's also data from our group and others that have shown that what's in the air that we breathe is very important. For example, pollution, focusing on PM205, that significantly changes the nasal microbiome. And we have shown the exposure to PM205 decreases a couple of good microbiome in the nose, that their job is actually keep the Staph aureus in check. So once they go down, Staph aureus increases. There's the endotoxin production in the nose that increases, and local endotoxin in the body is not good. While we need endotoxins in the outside of the body as a protection, once the staph colonizes and is in the body, increased endotoxin is associated with atopic diseases. So in short, PM205 exposure can have a problem. So overall, this is sort of showing the impact of the environmental exposures. So in summary, when we are asked what has changed that resulted in this significant increased rate of allergies, there are many factors, but these are some that we can sort of talk with our patients because they have a question about that child that now is allergic, but also they ask you like, what, I'm pregnant again, or we're talking about like other children or the next generation, is there anything we could do? So what we know is that a diet full of simple sugars and saturated fat can definitely be contributing to development of allergy. So really giving your child candy all the time is not any favor. It's not only bad for their teeth, but also can result in more allergies. The air we breathe is important. So if you live in a city that is impacted by high pollution, this is not going to be just in respiratory health, but can cause more inflammatory diseases, including allergic diseases. The home environment is very important. Cleaning all the time in the obsessive compulsive way that unfortunately, as modern human, we have adapted to is not necessarily a good thing. Using on the kitchen surfaces, all these surface microcidals that kills everything will only create more and more of the problem. A lack of exposure to animals and exposure to allergens also is important. So biodiversity, how taking our kids to the forest, to the nature, bringing animals in and embracing that, increasing their exposure is another thing that we can do to fortify the gut microbiome. With that, I would like to acknowledge all the people who have collaborated with me all these years for the view of the studies that I shared with you today. Thank you very much for your attention.
Thank you, Maha. Thank you very much. This is something different which you are bringing about the microbiota and which we really understand, or we really, you can say, like acknowledge. And we understand that in India, actually, what we feel is that the chances of food allergy is still very low, probably because a lot of beneficial effects which we are getting from the environment, one of them seems to be the microbiota. So the first question to you is, we'll start from you only. So the first question to you is that, yes, you have highlighted a very important aspect. Now the question is that suppose how we can replicate all these studies on the bedside. That means if we want to ask you that, okay, in this particular person, which microbiota or which probiotic I should start, at what particular age I should start, what should be the dose, and for how long should I start? For what should be the duration?
Sure. So the studies on use of probiotics is all over the place. Many of them are negative, some of them are positive. Bottom line is that they do not change the gut microbiome for a very long time. So use of probiotics, at this point, I cannot unfortunately tell you with confidence that it is shown to be completely protective or not. There are some clinical trials, and hopefully we'll have some good data on that. But what we could say to our children, and that would apply pretty much to everybody, that early exposure to nature and dirt from very, very early on is very important. So really like taking the infant to the nature as much as possible. And also as they grow up and start crawling, let them crawl and do not like have an alcohol swab attached to every diaper bag is important because as you said, in India, you're still protected. And this is the time and zone you should actually start changing, that you do not see the pandemic that we see with food allergies, because then now it's like majority of the continents are really impacted by. Our latest study showed that in Middle East, the rate has almost threefold increased. So like every child, as much exposure to nature as possible. And then like the hygiene practices that are not necessary should not be implemented. Only the necessary ones should be really implemented.
Any comments of on the, you can say like the prescription of probiotic to pregnant females? Means like early, like really early.
So that was also studied, and I did not seem to be much affected.
Okay.
Because there are, and then the probiotics also, there are many different things, like there are bifidobacterium-based ones, and then there's lactobacillus-based ones. That is shown that not to impact the vaginal microbiome sustainably enough that would impact the baby.
Going with the same scenario, you mentioned that using disinfectant during, you can say, like floor mopping. So I understand that using disinfectant during floor mopping might reduce the, you can say, like the variety of microbiota, and ultimately it might increase the, you can say, like the chances of allergenic problems. So the other aspect is, like for an example, we understand when we are talking about pest control, especially the cockroach control, then at that particular time we are advising that, okay, you should try to keep the things clean because cockroaches like the places which are dirty. So at that particular time, if you are using some professional pest control, you are using some disinfectant, then at that time we are trying to aim to reduce the cockroach concentration and in a way trying to reduce the cockroach allergenicity. So on one hand, when we are talking about food allergy, the disinfectant seems to be increasing food allergy manifestations. The other hand, the disinfectant seems to be decreasing cockroach-induced allergic manifestations. Where you would like to comment upon the balance among the two?
It is tricky, right? At the end of the day, they are in a way controversial. But I agree that really like pests in the environment, especially cockroaches, are not good. It's actually our group that shows higher exposure to cockroach and dust mite increases shellfish allergy in the child. So even in the context of food allergy, decreasing exposure to cockroach is important. So when we get to certain pests, I think we lose the battle for microbiome there. So that gets the priority of as much as possible eradicating those from the living environment of the child, not only for allergen exposure, but also they bring certain other problems and illnesses that could be more acute or more of a problem. And at the end, as doctors, right, it's an art. So we would sort of try to find different solutions as moderation as possible.
Great. Thank you, Maha. So, Sai, I would like to ask you a few questions. So my first question is that you mentioned about certain children in which the skin prick test was negative and still there were chance of probably severe reactions, though the chances were less, but yes, there were chances. So what are your comments about a true IgE mediated food allergy? Is it quantitative or is it qualitative?
Good question, Niraj. In medicine, you never say never, right? There's always these weird cases you get here and there. It sort of humbles you when you come across those. You're like, oh, I know everything. You're going to go ahead and do a skin prick test, and some reason the child didn't react. Maybe the test wasn't applied properly. Maybe the extract was faulty or whatever. Then you do the in vitro test, and then you're sitting looking at those and trying to see whether the immunocaps were reactive. And again, sometimes you end up having a negative test. So it's not an exact science. I always say that there's an art to practicing food allergy. There's always those caveats. There's always a few instances where you may see a patient where you feel like they're going to pass this food challenge 100%, and then they surprise you and they fail. So, it's not an exact science. There's a lot of art to this, and that's why, when I try to talk to clinicians, I'm like, you can't draw a blood test and draw conclusions. You can't do a skin test, draw conclusions. You really have to take the entire history, the entire reaction, history, and then, take your tests, and they should guide you, but they're not always the definitive yes or no or clear-cut answer there. So it humbles us, but unfortunately, there isn't the absolute, test that we can say that you're going to be completely clear. There are those few instances, and like I noted before, sometimes they measure high, they measure really reactive, and they pass, and they're fine. They're eating them, so it is a complex process.
Great. Now my second question is related to the epitope, which you mentioned. I really like that concept. So means like we are in that phase right now in India that we are still trying to palate the concept of components, and we are yet not ready in our mind about the concept of component. And now you have thrown another thing out of the basket, which is epitope. So is epitope is something which is beyond component you are talking about, like ARA H And then after era H2, you are talking about, or era H8, you are talking about now further, you can say like bifurcation of the component. You're talking about that?
Yeah. Yeah, so the epitopes, what it is it's measuring reactivity to the RAH2 protein or the molecule. So now we're talking about specific amino acid sequences within RH2 that we're starting to see confers the IgE binding and then confers the allergic reaction that we have. And based upon the testing reactivity, the RA008, 0.19, depending upon those sensitization and the measurable antibodies to those two epitopes, we can then clinically infer, are you going to be low, moderate, or high risk for reactions? And the cutoff was like 144 milligrams. So, we always want to know, can you have cross-contamination? Can you read, is it trace amounts that's going to elicit a reaction? If you know the epitope binding and you have low binding, then you may be able to tolerate 80% chance of tolerating a higher dose of peanut exposure versus somebody who's got high specific binding to those two epitopes, and then therefore they may have a more further clinical reaction. Issue is it's not yet ready for prime time, and meaning that there's still a little bit of research to go through. There's still, we're trying to ascertain whether or not it's if you have high levels of antibodies, whether or not those epitopes correlate well, or if you have low levels of antibodies and so forth like that. So there's still some caveats to be there, but it's another tool we have, and parents want to know. They want to know, what's their chances of kid having an anaphylactic reaction? Do I need to worry about airplane ride? Do I need to worry about going out to like Chick-fil-A and other restaurants and things like that? Even though we know it's okay, but I think the fear of a reaction is what holds these parents back. And by doing the epitope testing, it gives us just a little bit more knowledge about how much avoidance needs to be done, and then also the potential for allergen immunotherapy as well.
Okay. Do you want to say that epitope testing, once it is available, let's take an example, epitope testing, is it going to replace oral food challenge, or oral food challenge still remains the gold standard and epitope is still inferior to oral food challenge?
Oral food challenge will always still be the the gold standard. I think epitope will guide us in, some of those patients who don't want a food challenge, some of those patients who may want to start oral immunotherapy and don't want to go through a food challenge. Like I mentioned, the Consortium for Food Allergy Research, the COFAR centers, we're going to be doing a pilot study starting in January, and we're looking at what could replace an oral food challenge. And in that, we're looking at BAT, looking at MAT, and, mast cell activation. We're looking at TOOL as a potential device. We're looking at bile surface markers, where the kids are going to wear a watch, and we're going to be able to measure blood flow, pulse oxygen, heart rate, and other variability as well. We're also taking a look at the diastolic blood pressure and taking to see if that has any correlation with that. There's some preliminary work that we've seen in poster presentation where the diastolic either goes up by 10% or 10 millimeters of mercury prior to the next eliciting dose reaction. So what we're all trying to do is we're trying to find something that's going to substitute the oral food challenge, and we're getting there. I think that the COFAR study that's coming up, as well as the epitope testing, as well as the BAT, the basophil activation test, will guide us, hopefully, in having at least a 99% certainty, like, okay, this child's going to react to peanut, but maybe react at like 400 milligrams and greater, and/or potentially be able to do an oral immunotherapy or SLIT, or even even other potential high dose oral immunotherapies and so forth like that. So the younger we get them, meaning the age between 1 to 3, the better chance we have to reverse, especially peanut and other food allergies. So if we can replace an oral food challenge, take out the fear, and have some sense of some idea about this kid's going to react, so we need to start secondary treatments, that's where all these tests will be helpful.
Great. My last question to you is that in your practice, like whenever a child, you are diagnosing that, okay, this child is having CMPA, how many times you are stopping, or you need to stop mother's dairy product if the mother is lactating? So in a lactating mother, when we need to really stop the mother's dairy product if the child is diagnosed with CMPA?
Cow's milk protein allergy, I mean, most of the times I don't stop the milk in the maternal diet. I will take the history and see if there's clinical correlation. Most of the time it's quasi, the kid's a little fussy, kid spits up a little bit. I mean, now if you have like blood in the stool, which, the gastroenterology, talked beforehand, noted that there was, FPIAP, whatever, food, protein-induced enterocolitis or proctocolitis, where you have blood due to maternal ingestion of milk. That's the only time where I suggest that maybe stop the milk for a couple of months and then reintroduce it. But right now, we waffled from inclusion to avoidance back to inclusion now, including for peanuts and tree nuts and all other protein or allergens. Now, the avoidance of these products in the breast milk is not necessarily the practice, or at least the standard that we're employing. And maybe, just maybe, it could produce some tolerization, a process. So if you completely eliminate it and then you introduce it orally, are we going to be missing that, that tolerance process? And now, babies drink, and you got sublingual, some sublingual exposure there. So I think it's beneficial. I don't take peanuts out of kids' diets, even though they have a peanut allergy. I tell moms to continue eating it there. Right now, the evidence does not show us that removing these foods from the diet has any beneficial or like harmful effects right now. I think it's more beneficial. That's just my, take of, clinical practice for 32 years. But there are some physicians that will take it out, but I say leave it in.
Great. Thank you. Thank you. Dr. Nishant, one question to you. There was a recent study which was published, and you are also one of the team member, about the food challenges in Indian conditions, especially the milk challenges. So I would like to request you to highlight the salient points from the study, that how feasible you have made that the milk challenge or the milk product challenge can be done in Indian settings.
Well, this actually, the thought process started during the COVID times. And we actually, as a bunch of pediatric gastroenterologists, along with a pediatric allergenist and a pediatric gastroenterologist abroad, along with a nutritionist, so almost 7 or 8 people, we had a lot of teleconferences, video conferences with regards to the development of an Indian milk ladder, because we didn't have any such thing in India. So primarily, we know that in India, most of the milk protein allergy kids are non-IgE mediated, and there's a big question as to how we can reintroduce milk protein in the diet. And we did not have any Indian-based studies as far as the milk protein content of any of these milk ladders which were available abroad. So what we did was, and we had gastroenterologists from each zone of India, northern India, southern India, eastern, western, as well as the central part of India. And we drew down a list of foodstuffs which most of these pediatric gastroenterologists had used to initiate introduction of bovine milk protein in the diet of these children after a period of abstinence. And we actually calculated the protein content, and after having a fixed a documented way of preparing each of these Indian foodstuffs, because we wanted to provide a food guide to the Indian parents of Indian food household made foodstuffs, wherein they could actually gradually increase the protein content and the cooking times, so as to be able to make increased these children tolerant for these products, the milk protein. So we started with biscuits, and in fact, one of the foodstuffs which you would find are in Indian milk ladder, which is a 6-step ladder, is that biscuits, while they do find you find them at the entry point, there is this concept of introducing desi ghee, which has the minimalistic amount of protein, and it is quite indigenous to our population, because desi ghee is something which is not found in anywhere else in the world. So we did introduce desi ghee, which is home cooked, and there's which is actually predominantly milk solids with a very, very minuscule amount of protein. And it was a unanimously agreed upon point that desi ghee was something as an entry point in Indian children to actually induce compliance to this drug without these foodstuffs, and followed by milk cookies or gajar halwa, and then progressively rasgullas and other foodstuffs. So this is a 6-step ladder. In the 6th step, we introduce the pasteurized milk. The idea being that we introduce with small amount of milk proteins and gradually increase the amount of protein in cooking, and then increase the amount of protein with less amount of cooking, and so that the pasteurized milk actually comes at the last. It has been very well taken and published, and it has been very well accepted also by various pediatricians across India. And we would like to now have a second part of the study wherein we take information from various parts of India and then publish uh, a study which actually highlights how this has been taken and if there have been any caveats or any uh, actually analyzing the pros and cons of such a procedure. But this is for the first time a milk ladder wherein the protein content has been used and measured prior to introduction and prior to giving such a ladder into the population. And I hope that it continues to help the pediatric population as well as the pediatricians, the caregivers who can actually now advise Indian parents as to how to introduce milk protein in the diet of these children.
Great, great, sir, great. So the pediatric allergist which you are mentioning is Karina Venter, and Karina Venter is one of the colleague of Sain. So she worked at Chicago CFAR for a long time, and now she has been associated with the next university. So now there is one question which I would like to ask to from all of you. So which food is safest to introduce to infants suffering from FPIES? So I would like to take first the opinion from West. So Sain, any food item which you would like to probably prescribe in children or infants with FPIES? What do you think in your settings? Sai or Maha, anyone?
Well, it's interesting, in our areas, we see a lot of grains that come up. Interestingly, rice is common, oats, barley, and so forth like that. We're seeing a lot more egg, and we're seeing a lot more peanut starting to come through too. So, I've seen more peanut in the last 4 years than I did in the last 25 years. So I think the foods, you know, I would say fruits and vegetables probably are probably the safest. Although I've seen some, we do have an avocado FPIES in the Can Do study. We do have, kiwi too comes up. So the safe foods, I think majority of them are safe. But I'd stay with, the grains. If you do trigger it, one grain, then of course the next grains you got to be careful for. Interestingly, we're starting to see a little bit of a noise with the egg in some of our clinical studies, more so than the peanut. So egg and milk are starting to come out a little bit more now. Maha, I don't know about your experience, but similar.
No, I agree. I totally agree with what you said. I'm great.
Dr. Nishant, sir, anything to be added from your side?
I think in our Indian population, we have found, yes, fruits and vegetables are the safest. But I think rice has been quite accepted and by most of these children, and they have really, as part of the grains, the carbohydrates which we provide through the rice, they have really done well. But yes, I think the safest bet still would be the fruits and vegetables. But yes, rice is something which across pan-India, most of the pediatric gastroenterologists would find the safest bet pan-India.
It's interesting because we see rice here, and rice is not a main staple. So it's just different, right? In different regions of the world, we see different foods. But and rice is not a protein; it's a carbohydrate. So to elicit T cell response, to that magnitude, there's got to be some other cofactor with it that we're just missing.
Great, sir. I think it was an excellent panel discussion, excellent webinar. So I would just like to request at the last to all of you to please switch on your videos, Dr. Maha, Dr. Surinder, Dr. Deepti, Dr. Neelam ma'am. We will just take a photograph quickly and then thereafter we will wind up. Neelam ma'am, you want to say something?
Well, I thought I would just give the inaugural and move out, but it was so interesting that I did not have the courage to move out of it. I've been sitting all through and thoroughly enjoyed the sessions and the quick Q&As. There's so much to go, but what I really loved is what Ma said, that it is truly humbling. He said still there's a lot more he doesn't know, and he's the one who practices most. So I think that was one message which needs to be derived. What I wanted to ask is, if there is one thing that you think is the need to do research, what would that be? And what is that direction which you think is going to be an answer to all these questions that you yourself raised? And you said, I'm humbled, I still feel that there's so much I don't know. So what is it that can bring a revolution in this field?
Ma'am, whatever I understand is probably microbiota, and microbiota needs to be, because when I was in Chicago, I just mentioned one statement that it is the time to easternize the Western environment, and we have a very better environment. We need to really explore that what we have in this environment, and we need to give it to the world. So this is my thinking, but I am open for all the opinions, ma'am.
Yeah, I tell my patients, your first, I won't say, I don't call it a mistake, but your first exposure was having your pregnancy in the US. I said, go back to India, get pregnant there, deliver there, and then move over here. Maybe, potential could be helpful.
Baha, you have worked extensively on microbiota. What do you say?
So I agree. And it's all the practices, right? When you're living with your family and you're pregnant, what they feed you that you had no knowledge of, like that generational gap that will happen when somebody moves to another country. It's very hard to understand exactly what people are missing in the Western life that's increasing it. But we could all move to India during our pregnancies, it would be wonderful.
Yeah. I miss India.
We will bring you here. Don't worry.
I'm coming. I'm coming.
We will bring you. Great. Thank you. Thank you very much. Thank you. Thank you, everyone. Thank you, Neelam ma'am. Thank you for your time. Thank
Share
you.
his email ID and that thing to me.
Yeah. Thank you,
We'll
Mahat.
invite him for.
Thank you, sir. Nishant sir. Thank you very much. Good evening. Thank you.
Thank you, guys.